ahead.
Suffering and comfort. Are they ethical issues?
Some people make the argument, why have this particular section in an ethics podcast? Pain and suffering, are these really ethical issues? I make the claim that they are, because we have a professional ethic of life-saving that is so prevalent, so ingrained. This is a good thing, but when it comes to death and dying, we need to back off of that aggressive life-saving ethic. What do we do when cure is no longer possible? Clinicians need to remember that they have a corollary duty to beneficence, which is called non-maleficence. That's the duty to do no harm. And all too frequently, clinicians who treat terminally ill patients are reluctant to abandon their traditional role of curing the patient and fighting for life.
Suffering.
So suffering is not just physical. If you have ever met anyone with severe schizophrenia, depression, or bipolar disorder, you'll realize that some of those things do have a physical element to them, but those diseases are not all physical. Imagine the mental anguish when someone can't get out of bed due to one of these diseases. They want to, but they just can't. Or if they can't control their own emotions, where they have voices and ideas in their head that tell them to do things that they don't want to do. So suffering is not just physical. It can also be mental, psychological, or existential. And there can be a component of it that you can feel for someone or feel for yourself. So it can be self-regarding or other-regarding. There's an excellent quote by physician Timothy Quill that illustrates this. He says that we have difficulty accepting that for humans, death is sometimes the only escape from intolerable suffering. Allowing someone a peaceful, dignified death under such terrible circumstances can be a very sad, loving gift. Treating the dying. What should a clinician's focus be?
So what should the focus be for clinicians who enter the situation caring for the dying? They should change their focus from curing to caring. Substitute one vowel, an A for a U. Look beyond simply alleviating physical pain and recognize that suffering is more than pain, and such caring things could be, for example, talk therapy. I don't know about you, but it's not knowing that I'm going to die that is scary. It is the actual process. Is it going to be painful? What is it going to feel like? You also have to worry about the afterlife, so maybe invite religious counsel for your patients. There are many barriers to effective end-of-life care.
One of the barriers is the professional ethic of medicine. We know that referrals to hospice occur late in the process of dying. We know that over half of all hospital patients are enrolled for less than 25 days, and that more than 1/4 stay less than 1 week. However, the hospice benefit allows more than 6 months of time. So we're using less than 1/6 of that benefit when we know that someone is terminal, and that's because referrals are made way too late in the game. There are all kinds of things that could be done for people in hospice. It's not just about the patient, but it's also about the family. There are all kinds of bereavement and preparation for dying. There is symptom management so that people die in a comfortable way. And there are existential options, priests and rabbis. And this is a really great program for people and their families.
Another barrier is hospital infrastructure. Hospital structure and infrastructure is set up in a way that referrals to hospice just don't happen. The emphasis in hospitals seems to be on dealing with illnesses and not painful symptoms. They like to do stuff to you, fix you. Dying needs special attention. Hospitals tend to relegate visitors away from patients. There are special needs when it comes to dying. Hospitals are organized to fight death until there is nothing left to do, and when there is nothing left to do, they are often unprepared.
Yet another barrier concerns scientific mythology and lack of education about the dying process. In the addiction pathway, clinicians wrongly believe that the dying patient will become addicted to strong pain medications like opioids. And I have a question. Who cares? They're going to die. We know from research that the addiction pathway is in fact different. There's a slippery slope here. Sometimes providing adequate pain control may hasten death, whether we intend it or not. And again, I make the same argument. Who cares? If this person is dying and you hasten their death a little bit, but make them comfortable by doing so, then it can be that you've upheld your moral obligations to the patient. We also have the doctrine of double effect, which is an ethical justification for doing so. If your motivation is to kill the patient, we have something to worry about. If your motivation is to alleviate the symptomology of the dying process, and that is your only goal, and you do all of the medications properly, but still hasten death, that's okay. Still, it is a very emotionally laden situation. Some people believe you're killing people. That's just not the case.
The last barrier is a financial barrier. Control of pain is not considered an adequate reason for admission to the hospital. So if you go to a hospital in pain, they would ask what kind of pain. Most hospitals would then refer you to a specialist according to your response. However, this is changing a bit. There are now some good pain management centers and pain management teams. Also, a cause of the financial barrier is that insurance programs do not cover the increasingly sophisticated techniques used for pain control. Hopefully this will change also.